filmjölk med müsli.
Good afternoon, and most welcome to this event entitled The Silent Antimicrobial Resistance Pandemic Urges a Concerted Global Response, but what needs to be done? My name is Maria Teresa Bejarano. I am a Senior Research Advisor at the Swedish International Development Cooperation Agency, and I will have the pleasure to moderate this event together with Jonathan Eng from the Nordic Council of Ministries. This gathering is associated to the Stockholm Plus 50 conference, a healthy planet for the prosperity of all, our responsibility, our opportunity. It relates in particular to the Dialogue 2 of this conference, Achieving Sustainable and Inclusive Recovery from the COVID-19 Pandemic. During the session, I will kindly ask you to use the hashtag Stockholm50 to communicate and make questions if you want. The misuse of antibiotics has triggered a silent AMR pandemic, threatening global health and sustainable development, and leading to an estimated 1.2 million deaths every year, and affecting in particular low and middle income countries. Tackling AMR will be crucial in achieving sustainable development goals, but the response requires a One Health approach for a concerted response that integrates the animal, the food and agriculture, and the environmental sectors. As for COVID-19, new pathogens arise between the human-animal interface, hence the need to strengthen global health systems, including monitoring and surveillance of the environment. Improving infection prevention and control capacity, ensuring equal access to medical countermeasures, and reinforcing global preparedness are just a few of the learning the world has gained from the COVID pandemic. We intend to identify limitations and opportunities within the current global AMR response and ways to implement the lessons learned from the COVID pandemic and look for ways to scale up action for a global and concerted One Health response. This event is organized by the Nordic Council of Ministries, the Swedish International Agriculture Network Initiative, SIANI, that is hosted at the Stockholm Environment Institute, and is also organized by REACT, Action on Antibiotic Resistance. The Nordic Council of Ministries is the official body for intergovernmental cooperation in the Nordic region, consisting of Denmark, the Faroe Islands, Finland, Greenland, Iceland, Norway, and Sweden. SIANI Network supports and promotes multi-sector dialogue for sustainable agriculture, food security, improved nutrition, and the eradication of hunger. REACT, one of the first global independent networks to articulate the complex nature of antibiotic resistance and its driver, has nodes in Europe, Asia, Africa, and the Americas. We start with a keynote digital presentation by Professor Sabiha Essack from the International Center of Antimicrobial Resistance Solutions in South Africa and chair of the Antibiotic Resistance and One Health College of Health Sciences in KwaZulu-Natal. Her presentation is entitled "And Silences the Antimicrobial Resistance Pandemic, Policy Imperatives from COVID-19." Professor Essack, the digital floor is yours.
Thank you very much, Maria Teresa, and I wish I was there with you in person today. So distinguished guests, colleagues, ladies and gentlemen, good afternoon. I extend my sincere appreciation to the REACT Europe, the Nordic Council of Ministers, and the Stockholm Environmental Institute for inviting me to be part of this Stockholm 50 associated event. This is an overview of my presentation. I will cover the COVID-19 pandemic and response, the causes and consequences of AMR, policy imperatives, and then make the health and economic case for AMR. So everyone will agree with me that the world was caught with its pants down with regards to COVID-19. COVID-19 exposed huge fissures and dysfunctionalities in global health governance and local health systems. Countries that scored the highest on the 2019 Global Health Security Index and the Joint External Evaluation of the International Health Regulations had actually the highest numbers of COVID-19 cases and deaths. The green color on the JEE dashboard denotes a high level of preparedness. I came across this infographic on the history of pandemics and associated death tolls on the website of the Global Economic Forum. If we focus on the 20th and 21st centuries, then the leading causes of global deaths were the Spanish flu, HIV, and COVID-19 in that order, all viral infections. If we then annotate the AMR pandemic based on the recent paper in the Lancet by the Global Research on Antimicrobial Resistance Project, or the GRAM project, then we see that AMR is a very close fourth in terms of AMR associated and AMR attributed death. But this is in one calendar year. AMR has certainly exceeded pandemic proportions. So AMR adversely affects humans, animals, plants, crops, the environment, and their various interfaces and ecologies, as evident from this infographic on the epidemiology of AMR. AMR is a One Health issue, as we all know it, and its impact is so much more far-reaching than COVID-19. Climate change, termed the threat multiplier, is exacerbating AMR and vice versa, as shown on the second infographic. For example, increasing local temperatures was associated with increasing antimicrobial resistance in common pathogens in a study conducted in the US. According to the FAO, intensive livestock farming that depends on antibiotics generates more greenhouse gases than the global transport sector. There have been reports of antimicrobial resistance genes being released from the permafrost in Siberia and Alaska as glaciers melt, and sea level rises have caused ocean currents to move, and with them, antimicrobial resistance genes. These are the drivers of resistance, as reported in the closeout report of the Interagency Coordinating Group on AMR. We firstly have the misuse and overuse of antimicrobials, poor access to quality, affordable medicines, vaccines, and diagnostics, lack of awareness and knowledge in humans, as well as terrestrial and aquatic food animals. There's poor infection prevention and control, transmission of resistance pathogens along the food production and supply chain. The misuse and overuse of antimicrobials and poor infection and disease prevention and control in plants and crops, the discharge of waste from healthcare facilities, pharmaceutical manufacturing plants, and farms, lack of access to clean water, sanitation, and hygiene, poor infection and disease prevention and control in healthcare facilities and farms. And the impact of this is far-reaching, as I've mentioned before. It includes risks to food and feed production, businesses and trade, interaction with climate change, increased morbidity and mortality in humans and animals, as well as economic damage, loss of productivity, and increased healthcare costs. Let's look to the AMR sensitive aspects as well. Most of us are aware of the global sewage project that monitors antibiotic resistance genes in sewage in more than 60 countries. Results from this global project showed that the abundance and diversity of resistance genes was higher in low and middle income countries, and that AMR levels correlated better with socioeconomic factors rather than antimicrobial use. And the socioeconomic factors include infrastructural aspects, including wash infrastructure. This global study by Collinon and colleagues on the anthropological and socioeconomic factors that contribute to antibiotic resistance showed that while inappropriate antibiotic use was the driver for the emergence of resistance, AMR-sensitive drivers also played a role. The authors showed that the poorer the governance, the higher the ratio of private to public sector expenditure, and the higher the temperatures, again a climate change issue, the greater the level of antibiotic resistance. In contrast, the higher the GDP per capita, the higher the public healthcare expenditure, and the better the education and wash infrastructure, the lower the levels of antimicrobial resistance. So what are the policy imperatives to address AMR pandemic? Countries should first and foremost deliver on the international commitments that they signed up to. These include, but are not limited to, the UN General Assembly Political Declaration on AMR, signed in 2016, the World Health Assembly resolutions on AMR dating as far back as 1998, the international health regulations, the Paris Agreement on climate change, and of course, the Sustainable Development Goals. AMR should definitely feature in the International Pandemic Preparedness Instrument, and it is commendable that the US and the UK has established a task team that are currently revising the international health regulations as an interim measure. AMR-specific policy imperatives are related to antimicrobial use and stewardship. The 4 R's in human health and the 5 R's in veterinary antimicrobial stewardship. And these AMR-specific policy imperatives should span the entire life cycle of antimicrobials. So countries should introduce, revise, or optimize antimicrobial use regulations across the antimicrobial life cycle. They should similarly optimize clinical and veterinary antimicrobial stewardship policies at user, local, and national levels. introduce incentives for compliance and or punitive and substantive punitive measures for non-compliance, monitor and evaluate measurable indicators for improvement in antimicrobial use and stewardship, and ensure adequate enforcement capacity. Almost all countries have very good policies written with relation to AMR, but the enforcement capacity is wanting. The Collinon paper that I mentioned earlier concluded that the reduction of antibiotic consumption or antimicrobial consumption will not be sufficient to control antimicrobial resistance because contagion, the spread of drug-resistant strains and resistance genes seem to be a prominent contributing factor. This is a figure from our commentary to the Collinon paper where we highlight the importance of AMR's sensitive mitigation factors, improving sanitation and water infrastructure, ensuring good governance, increasing public healthcare expenditure, and better regulating the private health sector are equally necessary to reduce global antimicrobial resistance. We highlight the underpinning importance of adequate and sustainable human, infrastructural, and financial resources, and the overarching need for behavioral change based on the COM-B model or the capability, opportunity, and motivation model to address behavior change. So what do we do? What are the learnings from COVID? First, we engender political will by building on the lived experience of the COVID-19 pandemic and its health, social, economic, and political impact. We present AMR as the one health pandemic that is adversely affecting humans, animals, plants, the environment, and their various interfaces. That AMR is a one health issue and its impact is so much more far-reaching than COVID-19. Second, we emphasize that AMR requires the same whole of society, whole of government response, top-down and bottom-up from policymakers through to civil society, as is currently in place for COVID. The caution I would introduce here is to ensure consistent, accurate, and tailored messaging at all levels, taking due cognizance of differences in health literacy to ensure the whole of society ownership. Monitoring and acting on misinformation and disinformation is imperative. In terms of making the economic case, first we emphasize the return of investment in AMR containment, which ensures healthy people, healthy environments, food safety, and food security, as well as growth in the economy. Here we also include the cost of inaction. What will it mean if we do nothing? Second, we advocate for investment in both AMR-specific and AMR-sensitive policy and practice interventions. So to conclude, AMR mitigations needs the optimization and implementation of global and local policies, stakeholder ownership of the policies, and adequate enforcement capacity to ensure the availability of efficacious antimicrobials for future generations. I thank you for your attention.
Thank you so much for this complete review of AMR and so updated. Sabiha, in your presentation, you highlighted how climate change can further exacerbate the AMR issue. I would like to ask you, what can we as AMR community learn from the climate change movement that can place this in the spotlight the AMR as at the global level?
Maria Teresa, I'm going to answer that question rather pessimistically and I'm going to apologize in advance. So global commitments and declarations like the Paris Agreement on climate change fail because of the lack of accountability and the lack of consequences for inaction. So for example, the Intergovernmental Panel on Climate Change released its assessment report last year and showed that human influence has resulted in unprecedented increases in temperature, rising sea levels, greenhouse gas emissions, and all of these are happening much faster than was originally planned in the Paris Agreement. Similarly, for AMR, the 10 million deaths by 2050 predicted by the O'Neill reports was an underestimation based on the Graham report, which says almost 5 million AMR associated and 1.3 million AMR attributed deaths. So the question is, what is the solution? All of these declarations, countries may choose to do or not to do what they signed up for. So the soft touch is perhaps a league table of baseline AMR data and proportional or percentage improvements over time. So countries can compete each other compete with each other to make sure that their AMR mitigation efforts are better than others. The hard touch would be sanctions of some sort, perhaps. I am not in the political arena, so I'm not sure what can be imposed when global commitments and declarations are not adhered to.
Sabiha, maybe in a short time, if you could answer, you mentioned the AMR is often addressed as a silent pandemic. However, in the global scenario, there is not a policy framework that addresses AMR. So do you think that AMR is not unanimously acknowledged as a pandemic? And what do you think that a new legal instrument such as the pandemic treaty could help in addressing AMR?
Sure. So just to say that we do have an international policy framework in the form of the international health regulations, and AMR features quite prominently in the international health regulations, but we saw how inaccurate paper-based evaluations are based on the joint external evaluations. So as I mentioned in my presentation, it is good that the international health regulations are being revised in the wake of COVID-19. So you asked why we consider AMR as a silent pandemic. It is rightly called a silent pandemic because we do not really know the actual mortality and morbidity and healthcare costs related to AMR. Death registers throughout the world in every single country record deaths as a result of infection, but not drug-resistant infections. Disability-adjusted life years again speak about communicable diseases as opposed to drug-resistant communicable diseases. So our data sets from everything in terms of AMR surveillance to deaths are really inadequate for us to really understand the impact of the AMR problem. And I agree that AMR absolutely has to feature in the pandemic treaty. But like all other global treaties, its success will depend on the accountability arrangements and the consequences for inaction for the signatories. So in all of the global treaties and the understandings that we put through, there has to be some sort of monitoring and evaluation and some consequences for countries that do not act as they had originally signed up for. Thank you.
Thank you so much, Sabiha. And there will be opportunities to ask Sabiha questions later in the event as well. So if you have any questions, just hold on to them and we will come back to that. So my name is Jonathan Eng and I work for the Nordic Council of Ministers and we are one of the organizers here today. And I'm just going to shortly mention a way for you in the audience to also participate in this discussion and to share your reflections. Because for us, this is a really important topic and we really want to hear from your expertise and knowledge as well. So we have a Mentimeter where you can submit your thoughts and we will now soon go ahead with the panel, and during that time you will be able to go into this Mentimeter and share your reflections, and I will then come up later and share that with the panel and hear their discussions around that. So please go to menti.com and add the code 62421803 and share your reflections. And you can now see the code on your screen, and it should also be available in the agenda that was sent out to you earlier. And we want you to share your thoughts and reflections on the question, what lessons learned from the COVID-19 pandemic can we use to effectively contain AMR development and spreading? And then there will also be opportunities for you to ask questions. So for the people online, you will be able to do that through the YouTube chat, and we are monitoring that and we'll bring them back later. And for the people here in the room, you can just raise your hand when we come back to that. But for now, go to the Menti and start sharing your reflections.
Okay, the next part of this event is a conversation between two experts in they represent different sectors and approaches. On one side, we have Dr. Sunita Narain. Please take your place. Sunita is an Indian environmentalist and political activist and a major proponent of the green concept of sustainable development. She directs the India-based Research Institute Center for Science and Environment that, apart from the environmental aspect, has also brought up a focus on the animal and environmental aspects of antimicrobial resistance. She is also the editor of the fortnightly magazine Down to Earth, And in 2005, the center, I think, it got the Stockholm Water Prize, and she has been she was in 2000, I forgot the year, you were part of the Times list of the 100 most influential people. We have also Dr. Anders Nordström, the Swedish ambassador for global health. He established the Global Fund to fight AIDS, TB, and malaria in 2002, and has been WHO's acting Director General, and also has been SIDA's Director General. Recently, he headed the Secretariat for WHO Independent Panel for Pandemic Preparedness and Response. Well, it has become clear that in order to tackle AMR pandemic, the world needs a multi-sectoral and multi-stakeholders approach with One Health. Nonetheless, there hasn't been a concerted One Health response to the AMR pandemic, and in a manner that is understandable because it's very difficult to concert the three different communities, the human, the animal, and the environmental health. Sunita and Anders, you are experts on the health and environment community and have the same overarching goal of developing and tackling antimicrobial resistance. So I will ask the same question to both of you, and I will start with Sunita. What are the constraints that haven't allowed so far the different communities to join hands and fight the AMR pandemic?
So, in my view, the main constraint is really the lack of understanding. And if you look at COVID, and the conference today is very rightly titled Lessons from COVID. I think the one biggest lesson that we've learned from COVID is how unprepared we were. And also the fact that we are looking at zoonotic diseases. We're looking at an extremely dystopian relationship that human beings have now with nature. And the fact that the response to COVID-19 has taught us that we needed to understand the role of prevention, water, sanitation. We needed to understand the role of public health, and we needed to understand the environmental issue when it comes to zoonotic diseases. So in some senses, the AMR issue, the silent pandemic as we all and rightly call it, is a reflection of what we went wrong with COVID-19. And that also tells us what we must fix. And the reason why we weren't able to, and we are still not able to bring these sectors together, though increasingly we are, is because many of these dots were not joined in the past. And I see those getting joined more and more, that because of COVID-19, we are beginning to understand the role of primary health care. We are beginning to understand the role of prevention. When it comes to AMR, we are talking about prevention. You do not, it was so clear that if you're talking about access to water and sanitation as the major driver to prevent the use of antimicrobial resistance and use. You're talking about food systems. How do you grow food, intensify food production without the use of antimicrobials, which has a lot to do with our relationship with the food systems that we are building, has a lot to do with the relationship with zoonotic diseases as we are seeing. So I see COVID-19 and, of course, the greater realization of AMR now coming into policy for us to bring these institutions together. So I'm not so pessimistic. I see a change in the understanding. I see institutions coming together. I still see that we need clarity in terms of how we move ahead, but I think that will happen.
Anders?
This is a very bad start because we agree, actually. I'm neither very pessimistic. I'm quite optimistic because looking back, I've been working on global health for more than 30 years. And first, we didn't speak about AMR only 20 years ago. Today, we speak about it much more. So we have more of a global awareness today. We don't have enough action, absolutely. But looking back, this week we are looking back 50 years. And there's been some mega trends, and I think we need to be aware about those trends because they have also influenced why we have the situation when it comes to AMR. When it comes to the demographic changes, what we need in terms of healthcare, but the food transition, what kind of food and how do we produce food, the energy transition, urbanization, megacities. There is a number of big trends. And in some way, if Hans Rosling would have been here, he would have said that, again, we have a positive development. The world is actually better. But if you look at some of those megatrends, they are actually going in the wrong direction, especially the ones related to our climate, of course. So the question is, how can we change those trends? What are the tipping points for us? And that I will reply to your question then, Maite, by this. I see that there is a lot of opportunities. It's not just a daunting sort of reality under the climate threat. We have opportunities for the co-benefits here. What is good for people's health is also good for the planet. What is good for the planet is also good for people's health. And I think we need to put that much more upfront, the positive opportunities, better food. In Sweden, I mean, people do not want to have food that is produced with antibiotics. They think that there are still antibiotics in the food. That's not the case, but it has helped changing then what consumers are asking for. If you, as a parent, goes to the doctors and they say, we would like to prescribe antibiotics, the parents say, is that really necessary? So we have changed in some way both the knowledge and the awareness in society. And there are those win-win situations. Clean air. It's nicer to bike to the work than taking a car, especially today in Stockholm. So, I mean, there are a lot of those positive co-benefits, and I think we need to work much more on those. And there are those synergies in between environment, climate, health, AMR, but also on the food and energy. So what will enable us to move in this direction, where I think we need much more research on, is not on the medical side, with all the appreciation for medical science, being a medical doctor myself. It's on political economy, understanding much more not what to do, but what will make it happen. What is it that makes politicians to take a certain decision? Why is it so that the Swedish Minister of Health and Social Welfare, she's very engaged in the AMR question today? Why? Why is it so that industry are changing their practices on AMR? We have a big issue because we would like industry actually to now do more research and produce new antibiotics, but we don't want them to sell too much. Big challenge. And how do we also incentivize basically people? And then you can move from political economy to behavior science, understanding what is it that really is triggering people to change their actual behaviors. I think, and for me, that's the most powerful part of this. But in terms of the politicians, because I suppose that's where we're speaking a lot, and a friend of me who was a minister in Botswana some years back, she said that there are 4 Ps that are actually influencing politicians. And this is a little bit of, I suppose, homemade political science. First is actually your peers. And somebody, or the colleague from South Africa was saying here about publishing data, peer pressure. If you're alone in a community of prime ministers, of ministers, and you're the only one, you will feel the pressure from the others. If you're not doing as well as your neighboring countries are doing, you will feel the pressure. So the peer pressure, important. Your people, the ones who's going to vote for you, what do they think? Important. Your partners, who are you partnering with? And here international organizations can come in. But possibly one of the most important factors when it comes to politicians and whether they will do it or not, are their personal experience. Can they personally relate to this? Have they been in the hospital? Have they suffered? Do they have a relative that have been suffering? That is possibly what is then. So do some research on the personal background of your politicians. So my sort of, I'm also optimistic, but I think what we need to learn more as a global community here is not about what the problem is. We have that on the table. What are the solutions? We know that we need more of rational use of drugs. We need some of the basics sort of here. We need to use antibiotics in a rational way, both when it comes to livestock, animals, and for human. We know it. We don't need any new knowledge, but how to make it happen. And for me, it's both the 3 Ps here, the politician, the private sector, and the people, and then the 4 Ps in terms of how you can de facto engage with politicians. Thank you.
Thank you, Anders. We have a little time to answer. Solving the AMR issues needs both a top-down and a bottom-up approach. But where in the middle, there is a ground for these voices to find each other.
So, I agree with Anders, but I think, Anders, we need a more global view of this, because at the end of the day, antibiotic resistance is both about the excess use and the misuse, but it's also the need for access to antibiotics. And we need to keep the issue of equity, and we need to keep the issue of the entire world always in front of us when we talk about this. And I think, therefore, I'm sort of taking your question a little differently to say it's not just bottom up, it's also sideways. It's about different countries, their needs, and therefore also what is it that they will need to do differently. So in my part of the world, India, the developing world, we are essentially arguing that we do not need to go the way that the Western world has gone in terms of using and misusing antibiotics. And we are seeing this for a very simple reason. We're not saying this because we don't want to make your mistakes. I mean, the usual that I hear on climate, oh, don't make our mistakes, but you know, we don't know how you'll get rich in any case, okay? But the hard logic of it is that we cannot afford the cost of containment. We cannot afford the cost of cleaning up. You can't afford it either when it comes to climate change. You cannot afford it either when it comes to antimicrobial resistance. But you have enough money to sort of, paper it over. We do not. So we need to be much smarter in the way we move ahead. We need to be able to argue that we need to use antibiotics, antimicrobials in a way that we minimize the use right at the beginning. And that's where for us, the preventive agenda becomes far more important than anything else. But this then takes us to the different communities, because at the end of the day, the bottom up will come when we can grow food, we can have milk production without the use of antimicrobials or minimize the use of antimicrobials. And this is where the world needs to come together. The North and the developing countries need to come together to do much stronger critiques of the intensive food farming systems. Something that we shy away from, some things that we say, oh, we can improve our intensive food farming systems by still using it, but making sure that there isn't antibiotic residue in the final food. We need to be able to critique the food systems approach much more strongly. And I agree with Anders, we need to look at drivers for change. I mean, I'll give you one driver of change that we had in India that right now. We know that TB is a very severe problem in our part of the world. So when CSE came up with a report showing how the most important drugs for TB use are also used in food farming, the government of India put an instant ban on the use of streptomycin and tetracycline for crop production. So, it's about evidence, it's about putting together information that changes consumer behavior. But more importantly, it's about finding alternatives and answers, both in terms of manufacturing, because most manufacturing is in China, India, Vietnam. So when you talk about this, we need to be very conscious of what this means in terms of affordability, in terms of containment systems. This should not become another trade distorting policy. We need to look for answers where they really need to be found. And I think that's where, to me, the bottom-up, top-down approach really needs to move sideways.
Thank you.
You can answer in 30 seconds.
Yeah. Now we disagree, because I think India can afford. And I think India might be in a very good position. You're not representing the Indian government, I know that. But I think the Indian government is quite in a good position to do quite a lot. If you look... So if you just look what happened now during the COVID-19, and if I look back historically what has been done in terms of vaccine production in the world, India has done quite a lot. India is a big power, and I think India can do even more also when it comes to AMR, but also about, it's not just about the technology and the money, but it's also about the values. And what you're doing in India in terms of having health and wellness centers, trying also to change the values. Is it to have the produced food, the fast food? Or is it actually to have the local food that I've always had, that I've always enjoyed? To be rich in Sweden, that is to have access to your own homegrown food and vegetables. And that, I think, should be something that we should promote.
I agree.
Thank you so much. And thank you for this kind of discussion and very engaged discussion. Please take your seats. The next part of this session is a panel with 4 panelists that also bring and represent different points of view and a variety of approaches. Let me invite first Dr. Andrea Caputo, representing the Global Advocacy and Awareness to Combat Antimicrobial Resistance. And Andrea is the Global Health Advisor at REACT. His work focuses on several EU and international policy dialogues on antibiotic resistance, including One Health, research and development, and cancer. He has previously worked at SIWI on issues of sustainable antibiotic manufacturing, and at FAO on the implementation of AMR national action plans. Our next panelist is Dr. Jungxia Zhong, bringing the UN perspective of the Quadripartite Alliance. And she also brings experience from Asia. Dr. Song's work at the joint FAO-WHO Center as a FAO AMR focal point and unit head. With extensive experience in the prevention and control of zoonotic diseases and AMR, she is leading the development and implementation of FAO's action plan on AMR and has significantly contributed to AMR tripartite and UNEP collaboration. She has more than 20 years of experience working at China's Ministry of Agriculture and Rural Affairs and at FAO's China's office. We also have Dr. Frank Aarestrup, bringing the perspective of molecular surveillance and experiences from detection in wastewater. He is professor at the Technical University of Denmark, and since the mid-90s, he has been engaged in emergency and transmission of AMR from food animals to humans. Dr. Aarestrup is trying to particularly focus on research and molecular typing and sequencing for improved global surveillance, exploring alternative ways of performing global monitoring, including the use of metagenomic analysis on urban sewage. Lastly, we have Dr. Edgar Brun, who brings the aquaculture environmental perspective and experience from the successful approach of salmon fisheries in Norway. He's the head of the Department of Aquatic Animal Health and Welfare, and he joined the Norwegian Veterinary Institutes in '96 to work with epidemiological research, and has headed the epidemiology section at the Norwegian Veterinary Institute. I would like to ask to each of you, what have we learned from the COVID pandemic, and where do we go from here from a One Health perspective? I will start with Andrea.
Thank you, Maite, for your question. I hope you can hear me clearly. And I'll start by saying that if we wouldn't have diagnostic tests during the COVID-19 pandemic, probably we will still be in the midst of the pandemic with high number of cases. Well, when it comes to antibiotic resistance, we don't have such type of tests that can simply distinguish between a viral and bacterial infection, or when they are available, they are highly costly, as we heard before. Also, another lessons learned from COVID-19 is that when governments do invest into research and development, we do see quite a quantum leap from research. Well, if we look at the AMR situation right now, we know that it's underfinanced. Just think about the Multi-Trust Partner Fund. There has been only 4 countries pledged to the Multi-Trust Partner Fund. Similarly, when it comes to the Global Fund, there has been a call for widening the scope of the Global Fund, both from the ICG, as we heard before from Sabiha, as well as after the Lancet editorial, after the Graham study. So it is important at this stage that there is a long-term commitment when it comes to AMR in terms of funding for far more than 4 countries. in order to establish and the development, the distribution, and access to medical countermeasures, including antibiotics and diagnostics. Another point that I would like to make, it's connected to the first one, and it's about access to antibiotics. And we heard that from Sunita before, because even though research might happen, it doesn't necessarily mean that reaches those in needs. And that has been exposed during the COVID-19 pandemic. We saw that when it came to vaccines, and we see the same issue when it comes to antibiotics. And if we look at numbers, even from the Gram study, we can see that children are dying on a daily basis for a simple infection. And it's not just infectious diseases and resistant infection that are causing such a high death toll, but AMR is also affecting non-communicable diseases such as cancer treatment. So I just want to conclude here, since I don't think we have much time more. I hope I can add some more points later. Then we do need for the public sector to coordinate the research in antibiotic resistance and for antibiotic, specifically R&D, in a public needs-driven way that is delinked, or in common words, detached from volume of sales and price. Thank you.
Maybe I would like to have your answer, Jungxia.
Thank you. There are indeed many of lessons to be learned from the COVID-19, and then I think it is important to really understand to what extent the difference of these two issues, and also clarify what they have in common. So, for example, COVID-19 was caused by an infectious agent, which is the main cause of the disease. But AMR is not a disease per se. AMR could be a critical factor for a number of diseases. So in a sense, AMR is more complicated than COVID-19. So given that, so for the common ground though, both issues have the concerns and consequences, socio-economic consequences, human health concerns, and also food security implications. So given that there are some of the lessons could be extracted from COVID-19. For example, surveillance and early detection. So we already learned it from previous, for example, SARS. And then we know it, but we didn't really learn that. So the earlier detection of the resistance, the quicker we can put in place the response, the measures. And they also contributed to efficacy and also reduce the scale of the problem. And then the second point I want to raise is that it is worthier to investing in preventing, not in fixing. So I think many of our colleagues already mentioned this. So we need allocated resources, and we want to avoid such massive expenditure associated with a pandemic. So if we put in prevention first, for example, in food system, I really fully agree with Dr. Sunita. So it was estimated more than 70% of antimicrobials being used in food systems. So reduce the need is really the key. If we try to encourage the farmers to reduce the need, less and less antimicrobials will be being used, less and less residues in product, milk and meat and eggs, and less and less AMR will be discharged to the environment, soil and water. So, in a sense, if we are looking at some key measures, we can put in prevention first. So, in food and agriculture sectors, reduce the need is really the key. So preparedness is another thing I don't want to repeat. I think the word we cannot afford another pandemic for lack of preparedness for AMR. So come to the One Health. So One Health is really essential for address AMR. Maybe we can do, for example, a One Health diagnostic at a country level based on their national action plans. We can really find the needs and the gaps and on their One Health capacities. So there are so many tools already available, can help the members, the countries to do their evaluation on One Health capacity. And then I just want to conclude, bring multi-stakeholder engagement to AMR. It is really essential. And also, I think this is also the idea of this Plus 50 Stockholm event. Thank you.
Thank you, Jungxia. Let's go with Frank.
It's absolutely essential. That has underpinned everything from the development of the first, serological and diagnostic test for COVID. Well, that was not done without, the sharing of a sequence, because you need to have these data first. But I think we can also see that you've seen this, that every country has gone for themselves, and basically there's been a very, very large delay in the data sharing, especially from the low and middle income countries, due to various aspects, but of course including some of the capacity there. But I think that bottom line is that without knowing where we are, we have no clue where we're going, and without surveillance, we are simply just flying blind. So I think that's, but I also think that we completely need to rethink the way we are establishing global surveillance. Right now, it's the classical WHO consensus. Everybody should generate their own data to the public health institutions. And we've been talking about this for, I guess, half a century now, and it is just not happening. So I think that we need to rethink a little bit exactly how do we actually generate global surveillance. I could establish a global surveillance program for AMR for all countries in the world for $1 million a year. So it's not a question of the funding. And developing that in all the countries will cost, I guess, $200 million a year. And that's not feasible for the world. So we need to rethink which kind of model do we actually want to go forward with in the future here.
Thank you, Frank. Now let's go to Edgar.
Thank you for the invitation. Being the last is always easy because most have been said. But I would like to sort of focus on One Health first. And COVID was an infection that not infected aquatic animals, but still it sort of turned aquaculture or put a limelight on aquaculture nevertheless, because it interrupted a lot of the supply chains, jobs, food security, income in especially in low income countries. So in that sense, aquaculture, even not affected directly of the infection, was infected by the pandemic. And that shows how all these food production systems are integrated when something happens. And that, I think, was maybe a benefit for aquaculture being included to a much more extent into this One Health concept. And knowledge about watersheds, water catchments, oceans, how they interact with the rest of the food production system is therefore becoming a very important issue. And I think that sort of can encourage also to take these kind of concepts into the aquaculture industry, which I think is very good. So the COVID has learned that we have one planet with one or several production systems that all are integrated, and we need to learn more on how to use our catchment area, water catchment areas and the marine environment. When it comes to antibiotics and AMR, we all know that antibiotics are easily available in many countries. It's easy to go across the road when the fish is not feeling well. You go to the nearest shop and you buy some antibiotics and you use it. And often the fish improves. So that is the concept. But you're using antibiotics because you have an infection. And I think for aquaculture, this has been, again, I feel when I'm talking to people, especially, we have some projects in Africa, that they understand more that infections can apply to aquatic animals as well. And that you need, that what you have learned yourself as a human being actually can really be applicable on animals. And therefore, words like biosecurity is a lot more easy to talk about now, and people understand a lot of epidemiology because of the pandemic, because they can sort of parallel what happens to them to the aquaculture industry. And that has created a potential or to actually improve biosecurity in aquaculture. We know that aquaculture is a very global industry, and one infection in one continent easily is transmitted to the rest, like many other diseases. So this actually applies to aquaculture very much, and that gives some hope. The other things I would mention in addition to biosecurity, and you will all mention surveillance, is transparency. The pandemic showed how important it is to know your neighbor. What happens to him? and that is a danger or a risk to myself. And that is something that the aquaculture industry has been very sort of careful about. It's been very secret almost, the disease situation. So this is also something that we can use and tell farmers that in order to control or combat or prevent diseases, we need to know what happens around us. We need to be open, because it's not a secret. It's not necessarily your fault that you have a disease. You're just exposed to some, you're just unlucky. So we need to have that. And I think that has sort of created a better environment to talk about transparency and data sharing and all these things. The last point I would say is also collaboration. We have a project in the FAO called the Fish Vet Dialogue, and it's where we try to engage different authorities to talk about, or to come together and talk about fish health and fish welfare and all these things. Because in aquaculture industry, there are very separated authorities. They don't talk much to each other. Veterinarian authorities have fish health in a way, and then the licensing is another place, and so on. And they never talk to each other, even though they have to do so in order to have a clear, concise management of the industry. And therefore we established this fish talk or a fish vet dialogue, and it actually was very successful, and FAO has encouraged us to go on to this on this path in order to sort of improve that collaboration. And that also came out from the COVID, that we need to collaborate in order to control any disease, also in aquaculture industry. And many have said it before, we cannot do this alone, and this One Health approach actually is the umbrella of collaboration. And we need to identify the various stakeholders. They can be someone you never thought about, but they are there, and they can actually make a difference in order to manage diseases. And if you do that, manage bacterial diseases, you will also decrease antibiotic use and AMR, because that's a product of consumption.
Thank you so much, Edgar. Let me make another question to Jungxia. What are the next steps of the Quadripartite Alliance, and what are the bottlenecks in the implementation of the AMR action plan? Maybe you can answer in around 2 minutes, Jungxia.
Okay, thank you. So actually, tripartite, that's WHO, FAO, and ORE, has been working decades. And then UNEP officially joining, so now it's even this partnership even stronger. So recently there is a document was published that is the strategic framework quadripartite. Now we see quadripartite. It's just recently published. It set out the goals for the next 5 years, how the 3 UN organizations work together with ORE to address AMR, and it also set out the intermediate outcomes and also longer-term outcomes. There's a concrete action plan was developed for the next 2 years. There's some prioritized areas was identified. For example, supporting the global governance. GLG was already there. The next initiative is the multi-stakeholder partnership platform. So this one, really, we would like to bring all the stakeholders covering the clusters, the governments, civil society, academia, resource partners, and private sector. So now where we are about this, we almost finalized the TOR. And yesterday I had a meeting with the quadripartite colleagues. We are discussing this platform. Hopefully we can get this launched as soon as possible, maybe in July somewhere. So for other things, and then one thing I would like to share, we are the 4 organizations, we are going to start to revise the global action plan on AMR. That one was published in 2016. With UNEP joining, of course, UNEP part, environment part will be included and strengthened. And then we just at a brainstorming stage, and for the next step, it will be put on the agenda of the 4 organizations. Thank you.
Thank you, Jungxia. Maybe I would like to go to Frank. and ask you, what are the challenges of setting up a global surveillance systems? And is there enough built-in capacity in low and middle-income countries? And what are the major constraints? What needs to be addressed first in these countries in order to have this surveillance system?
Yes, that's a good question, because I remember now we talked about global action plans. That's I was part of writing the global action plan for the WHO that was published in 2001, and it was also, I think, any action plan we've seen is surveillance is always mentioned, and it's just, I think you also need to realize that it's not that easy to implement, at least not with this what we call consensus-seeking approach we have right now, where we go through the WHO, the local governments, and they had to provide these summary reports. So perhaps we should actually also start to rethink a little bit the way we are generating and are accessing and are using surveillance data. And I think that if you learn from industry, you will very often see that a component for a car is produced in one country, something else in another country, and then it's put together in a third country. We wouldn't expect that all countries should produce the same cars and then use that. That's just providing isolates, and then you could actually have a continuous running system. At the same time, if you do not, and I'm not talking about, and then, this is just stealing the data away. No, you could actually take the data, analyze it, provide summary reports, and then give the data, the raw data, back to the provider, or keep it at a data hub somewhere where the provider has exclusive access to this. So the rights, the property, the ownership keeps with the data provider, the primary data provider, not necessarily the government, the primary data provider. And it would actually be quite easy to think about this. And I actually also think that this will be building more engagement, more capacity locally in low-income countries, rather than, for example, we've seen very large projects going out with governments. The Fleming Fund is one. What is it, 280 million pounds over 3 years? And I think it's really excellent that they're putting this effort into it. But if you look at it, I have not seen a large stream of data coming out in terms of global surveillance. And I also have a hard time seeing this building something that's long-term sustainable capacity. A global surveillance can be established this year, and I promise to do it. Otherwise, I could actually pay the money back for $1 million. I prefer if someone else would do it. Actually, to be honest, I work at a university, and I don't think this is my thing. But I can do it for $1 million a year and keep it running. And then I'm definitely sure anyone else can do it as well. So it's not a question of the funding. I think it's a question of thinking a little bit collateral and away from this typically, what we call political consensus seeking we sometimes have in the global public health system. So think novel and spend, the money more wisely and get more out of it, including more local capacity building where it's really needed at the frontline clinics, not necessarily at the central reference laboratories.
Thank you. Thank you so much. Andrea, Anders was talking about the change in behavior and the change in attitudes and the need to have this kind of, he talked about political science, but I think it's anthropological. What is, according to you, the role of raising awareness and behavioral change in the fight against AMR, and what needs to be done?
Yeah, I think that's a really good question. And if I can quote both Anders and Sunit, I think they both raised a good point. One talking about understanding, so lack of understanding, and of course there raising awareness is fundamental for everyone to actually get to know what is the issue and what are the gaps. And we shouldn't forget also the youth involvement. And if I can toot our own horn, REACT is working also with students, youth, and communities in different countries, or all over 5 continents, I should say, because that is fundamental. And also what Anders was saying before, the part of benefit, understanding the co-benefits between different parties. If I can also tap into that part of more the One Health approach, since I didn't have the chance before, I think it is crucial from what has been said before that there is no fragmentations between the different sectors, but there is more a funding, a synergy, and a system transformation in a way. And I think was Sabiha at the beginning also mentioning how AMR is a development issue in terms that taps into or jeopardizes several sustainable development goals, such as hunger, poverty, of course, health, and environment as well. So we should make sure that all these different issues are taken into account. And it can be just one voice. As I mentioned before, we work all over five continents, but we do need more actors, more civil society to work towards the same issues. Thank you.
Thank you, Andrea. I may go back to Jungxia with a question about, COVID is a zoonosis. And after this COVID pandemic, what do you think has changed in terms of understanding a zoonotic, the relationship between zoonotic and antimicrobial resistance? Has the understanding increased, and in which ways?
Yeah, I think it do help us to really looking at the relation to the zoonotic disease and AMR. If you look at our FAO, we have the new established center. It is really the center for zoonotic disease and AMR. Actually, in the very beginning, we put it as a zoonosis, and then when we proposed this proposal to our member countries, they said, "Why you don't put AMR there?" So it's from outside. People start to looking at the relationship to zoonotic disease and AMR. If we are thinking that, for example, both sides, both issues is really, for example, COVID-19 is a zoonotic disease. And then we are talking about COVID-19, the lessons learned from the COVID-19 is really, in a sense, kind of overall zoonotic disease and AMR. We can learn from COVID-19 pandemic is very much related with the zoonosis. For example, One Health approach is overall for COVID, for zoonotic disease and AMR. There are some capacities, there really overlap between zoonotic disease and AMR. If we strengthen COVID-19, I think it benefit for prevention, preparedness for AMR. And this is also mentioned by our other speakers. So, and what we can look, especially at a country level, so how they can collaborate between zoonotic disease and AMR. That is something we really should think about. At a global level, we see we have a tripartite, we have now quadripartite, and then we try to collaborate through the different networks and stakeholders. But what is happening in the country? How you can really bring the veterinarians talk with doctors, how they can make sure that people know what is happening around their neighbors. So we should really looking at a country level. So what we can do first, I just mentioned a little bit. We do a diagnostic. We are thinking diagnostic. We try to use some tools. We developed a progressive pathway tool. We call it FAO, AMR, PMP. So we go to the countries, we getting together all the partnership together, and then we can have a look. Okay, this is the checklist. Let us have a look, and what are the gaps, what are the needs, and then okay, we will propose action plan, and then we will suggest the resources. If you need this, you can go here. If you need that, you can go there. So we try to start from the One Health dialogue. When we do the PMP, this is the example. But I believe in our partners like WHO and the ORE, they also kind of have a similar. We try to do One Health evaluation to support this One Health to really facilitate the collaboration between zoonosis and AMR.
Thank you. You are an expert in zoonotic issues, so thank you so much for this answer. Maybe I would go back to Edgar. Your international involvement has been important to understand the complexity of global aquaculture that is usually not considered in many fora, talking about AMR and other issues. And as much as it needs to be, and you just mentioned that in your first answer. So what do you think we can learn from Norway in reducing antibiotics in our culture? I heard that you have been working in I don't know if it is Colombia, in other countries. So what are the lessons that you are bringing to other places in terms of fish aquaculture?
Before I answer that, I would like to go back because I forgot one thing. And when I talked about collaboration, one of the things that was very needed in this fish-vet dialogue was the collaboration between FAO and OIE. So we need to start there. The question you have is interesting, and It's a good question for Norwegian, but it's also difficult in the way that I'm not sure what we have done is very applicable elsewhere or easily applicable, because we are 5 million people and we all know each other, and it's very transparent society. So I realized that there are challenges in other countries. But basically, I could say that and yes, I don't remember who said so, but antibiotics and aquaculture or farmed fish, especially salmon, it's sort of said that you cannot eat salmon because it's full of antibiotics. And I strongly believe, and I can use numbers, but that the production of salmon has the lowest antibiotic use in all modern industrialized productions. So it's in Norway, and it's very, very efficient. But it wasn't like that. In the 90s, early 90s, we used a lot of antibiotics due to a couple of infectious or bacterial infectious diseases. And it was so devastating that there needed to be done something. And one of the things that was crucial was collaboration. And then we talk about collaboration between the industry, the authorities, and the research institutions. And together, they saw that this is important to go together and establish knowledge, establish system, establish biosecurity plans and so on in order to control these diseases. And luckily, we also, together with a lot of regulations from the 90s that still are in place today, we also had efficient vaccines. So we were lucky to have this situation in the early 90s that actually established a production that is guided to a great extent by biosecurity principles. And that industry was also much more family-owned than it is today, so it was pretty easy to do so. We also had an open culture. As I said, we know each other, and you cannot hide very much. So this openness and transparency was very important in order to establish system that could move us forward when it comes to the use of antibiotics. And of course, all reporting. We have a very tidy reporting system for all antibiotics. First, it needs to be prescribed by an authorized profession. It goes to the pharmacy, and they control it, they report it, and all antibiotics into the industry is sold to the pharmacies. And all antibiotic has to be approved, and they also have to be approved by a manufacturing, or the manufacturing needs to be approved. So everything is very controlled in the usage of antibiotics. And before you can use antibiotics, before you can have a prescription effectuated, there needs to be a justification for it. So you need to have a bacterial diagnosis, and it needs to be a resistant testing on it. So you know that the antibiotic that you're using is actually efficient. So all these regulations keep the antibiotic very low, in addition to that we manage to control the disease situation. I could also say that we have, of course, surveillance programs that run annually. So we have a surveillance on all use of antibiotic. We have a surveillance on possible resistance, and all this is also reported in the public domain annually, so everybody knows what's going on. And I think all this focus on the usage, the focus on why you have to use antibiotic, the controlled prescriptions and so on, and also that the industry is extremely anxious, I would say, of bacterial diseases, because if this breaks, it is a fragile thing, so if it breaks, then the reputation for the industry will be catastrophic, I would say. So this is how the system works, and it has been working for 30 years, and the use of antibiotic has been so far kept at an extremely low level. So how this can be applied elsewhere, I'm not sure, but it would be something at least to look into and see what kind of components could be useful in other production system, other countries.
Thank you so much. We have heard here many different perspectives and many different, you have highlighted very important and complementary things. And please, Anders and Sunita, may you come here so that we have all of you at the podium in order to answer questions from the public. Jonathan, do we have questions and reflections from the Mentimeter?
Yeah, we have had a very active audience online, which is very good. And we have now a full word cloud as well that we will share to all the participants afterwards as well, so you can all use this in your forward work. And we can see a trend in the reflections from the audience that governments need to take a big role. They seem to think that there's an urgent need for a stronger governance for handling AMR. And there needs to be a long-term vision for controlling AMR. And this also needs to come with funding for actually implementing these plans. And connected to this, several people also raised the need to invest in prevention and preparedness, which also then would save us money in the long term. And I think political will is really a key word and a key theme that reappears here all the time. And the audience, they seem to also ask then, but how do we create this political will? And will that be enough to address the AMR pandemic? And then we have a lot of more questions, but I think we should probably start there and hear the panel's reflection on that.
Okay, let's start with Andrea.
Yeah, I can start, and I think that's a really good question and speaks to the point that have been made before. And to begin with, I would say that the understanding and the part of awareness should be there. We should make a case for AMR. And we saw before some example, for example, with the climate change, and now with the COVID-19 pandemic, how the issue became an issue for everyone. Unfortunately, with AMR, in a way, we do not see, and I'm talking from a high-income country perspective, the issues perhaps on our, like with our eyes. But if we look at low-middle-income countries, and other people, I think, in this panel can speak as well as online, the issue is out there. So the first thing, I think, is to make sure that everyone is aware that this is a problem, this is a pandemic, and it's not, as has been mentioned before, a future pandemic, but it's happening now, even if it's silent. So I would say that's the beginning.
Jungxia?
Sorry, what is this question?
I just wanted you to
just a reflection.
Yes, just a reflection.
Okay, maybe
yes.
I can come to the point of political commitment. I think Dr. Sunita is here. So for quadripartite, we put much efforts on the global governance structure, in a sense to really promote the political commitment at global, regional, and national levels. So GLG did a very good work. They really play a significant role on advocacy and advisory role to the world, to the 4 organizations. And the independent panel, and they are now a little bit stuck, but the 4 organizations, we try to get it. So the next one is the partnership platform. So this is the 3 structures. The partnership platform, the role is really bring the policy, the high-level advocacy from GLG, and if we have independent panel, and really translate into actions at the countries. And then at the national level, also promote the political commitment and also encourage the stakeholder engagement. I'll stop there.
Okay, let's continue. Yes?
Yes, thank you. I think that's a very difficult question, because I think we've been trying for so many years to create a political will. But I do think that we cannot keep waiting for countries to get to some consensus. And I think that perhaps you should actually try and go out and generate data, so people, politicians, actually realize that they have a problem. So I think that the first step in creating political will is actually to create awareness that that individual country also have a problem. If we look a little bit back in history, and I'm sorry I'm getting that old that I start doing that, they could see, okay, what actually happened in terms of, some of the successful interventions in Europe on the antimicrobial growth promoters, that when it suddenly emerged that some countries were using a lot and had a lot of resistance, and you could do this benchmarking. You have EARS that started out of IVM, and now EARSnet, from the ECDC, longest running surveillance program, at least if you have a supranational one. And it's actually also been benchmarked for, okay, where should we do interventions on the human side? MRSA in the UK, it was also first when you start comparing the different hospitals that something actually happened there. Otherwise, nothing was happening as well. MRSA in Denmark, that was 1969. Once again, it was first when the surveillance data came out. And I think that this is basically the data integration there. And then I also think that we need to realize that, well, not all countries are equal. And I think it was actually put very well with Norway, because Denmark has pretty much the same system, but it's just not going to fly in Tanzania. Monday I'm going back to Tanzania, and I know I'm going to Lake Eyasi, and there's 8-9 hours to the closest diagnostic laboratory. And I'm not going to hide them where there's a further 5 hours drive. And even when you go there, they can only diagnose a few isolates, and certainly not any veterinary pathogens at all. And there's a lot of antimicrobial agents used there. And there are ways of doing surveillance there as well, and we also implemented that together with NIMRI in Tanzania. But the data needs to be there before actions are taken, and we cannot expect other countries to do what we do. So I think we should, generate some data and let countries implement what they want to do themselves, because locally they will know best what to do, and we shouldn't superimpose our Northern European, Danish or whatever, Scandinavian line of thinking, because that might not be the solutions that work in sub-Saharan Africa. And I'm sorry for talking for lengthy here, but I actually just calculated that we have over the time worked with more than 200 countries and regions around the world, some more, some less. But basically, I've learned a lot of smart people out there. And I've also learned that the solutions I come with are not always the best. Well, they actually very rarely are.
Thank you. You don't need the microphone since you have. Yes.
Okay.
Your microphone.
I totally agree with the last part you said, that there needs to be a national system developed for the specific area. I think that's also why I'm careful with this Norwegian thing, but it's an example, and it shows it can be done probably. I'm not sure I will elaborate too much, but I feel that knowledge is a very important issue here, and I am not sure that politicians and authorities are knowledgeable enough about the situation. And I talk now about aquaculture. I realized that when we talk to politicians and also some of the people in the administration, that the knowledge of disease and the use of antibiotics and these things are a little strange to them. And I feel actually that we have an effort to do when it comes to spread this kind of knowledge. The other thing I would like to emphasize, there are probably a lot of things to say, but I also would emphasize the importance of the authorities. The authorities are the ones that are regulating the industry, and that's why I also say knowledge in authorities and politicians. I see from the Norwegian industry that there's a lot of things to criticize, but much of it is because the regulation is not good enough, or that what you call it, how you impose the regulation is not good enough. The industry is there to make money, to produce food, and that's their business. But the regulation around these things, and it also comes to antibiotics, is set by the government. And I would like to challenge governmental authorities and politicians to be brave in these things. And you said something about the antibiotics in India, that they found that this was important for treating TB, and they were able to say, stop, we are not using this in agriculture. And I think that is a very brave, but it's very important that the politicians and the authorities are brave enough to say that this is allowed because we need antibiotics, and these are not allowed, and we need a certain regulation in order to get access. I know it sounds from a Norwegian, but I think that is something that many countries could do a lot better. Thank you.
Sunita.
So
I think a lot has been said. I just want to reiterate, I think it is, political will is a combination of two things. One, of the information and the pressure that it gets put because of public pressure, but two, political action is different from political will. And political action is about being able to find affordable and inclusive ways to be able to move ahead. And that's important from our point of view, because affordability is important for us. So when CSE did its test on, say, honey, and we tested for antibiotic residue in honey, it led to a consumer pressure, and standards were put on eliminating antibiotic use as growth promoters, or even for therapeutic use in beekeeping. Same thing happened when we did something for chicken. Same thing happened when we did something for crops. That's what led to the ban on the 2 antibiotics for crop production. So consumer pressure helps, but that is not enough. We need to find ways in which, and that's the lesson we need to take from the climate action, because climate action, there is public pressure, but we are still not seeing action at the scale and pace that is needed. And that's because as yet, countries are still addicted to fossil fuel. You can call it gas or you can call it coal, but it's still fossil fuel, and everyone is addicted to it equally. So I think we need to keep the climate lesson in mind and keep focusing on the roadmap ahead, because that's when the political will translate into political action. Anders.
No, thank you. Addiction is interesting. I think addicted to fossil fuels, addicted to sugar, addicted to smoking. I mean, we have a lot of bad addictions. The question is what we can learn for how we manage those addictions, but that was not what I was going to talk about. But some reflections on the questions. 3 words that comes into my mind. The first one is really to unlock the opportunities. We've been speaking about surveillance. There are quite good surveillance systems out there that we're not using for AMR today, also in very resource-constrained settings. I was the head of the WHO country office in Sierra Leone during the Ebola outbreak. We built one of the best integrated disease surveillance systems in Africa today, during the Ebola outbreak in one of the poorest countries, now monitoring 26 different conditions. Unlock what is there. The investment from the Global Fund in Gavi in today in information and surveillance system is huge. In the past, when we spoke to AMR, we didn't want to be in the same community as HTB and malaria. Today, it's okay. So let's join hands and let's unlock resources that are there, because it's the same surveillance we need, the same labs that we need to have the capacity from. The second one is about incentivizing. So unlocking, incentivizing, and I don't think it's enough with knowledge for our politicians. And as I was saying before, we need really to understand what is incentivizing politicians, but what is also incentivizing private industry, private companies. And the example from Norway saying this would be a disaster if they would know that we were doing that, so they are not doing that. That's a very strong incentive. So understanding the incentives for changing behaviors, politicians, private sector, and people. And the last one is the last word then, unlocking, incentivizing, co-creating. Co-creating and working together, especially at the local level. Because here, in communities, at the city level, by co-creating and coming together different actors, researchers, activists, together with governments, then we can actually make a difference. But we need to believe and to make that happen by co-creating. I think we can make a difference. Thank you.
Yeah, and we have several more questions online, but we don't have a lot of more time, so I will choose one question online, but then also give the opportunity for people here in the audience, if there's anyone, just raise your hand. But we have one question here about point-of-care diagnostics in AMR, and they wonder, are there currently any economically feasible diagnostics that can be widely implemented in a low-middle income context? Is there anyone who wants to answer this question?
You already mentioned that, Anders, now that you said. But,
I think there is need for more. I mean, if there is something we should learn also from this pandemic in terms of how rapidly we were able to develop a vaccine and get the production. We did not do so well on the diagnostic, but neither so bad. So there was a number of rapid diagnostic tests now for COVID-19 quickly being developed. So of course it's possible, but I think for the specific microbiomes that we are thinking about here, there is a need for more. But a lot has happened.
And you, please?
Yeah, well, just a short case story that in February I was in Tanzania. We were actually going to sequence, doing field sequencing in a water hole, but got a call from a local hospital, Machame, up in Kilimanjaro. A child, 2 years and 7 months, diarrhea, getting, a kind of, quite sick. They did not respond to ceftriaxone. They started to give a blood transfusion. So we drove there and used a flow cell. That's a $1,000, so analysis. So that's the point of care, but that's still sequencing the feces, identifying it within, in 8 hours. Campylobacter, ceftriaxone is not the appropriate treatment. Changed to macrolides, and 3 days later he was home. So yes, it can work at least, and I must say I have also just experienced that myself. But for $1,000, per test, that is not the way forward. But I do think that in a country, for example, like Tanzania, where I know they simply cannot isolate the Campylobacter that they are there. And it's not because of lack of will, it's because of the storage of the plates. Then having an appropriate treatment as some kind of a rapid test would really be absolutely very valuable. But not in the reference laboratories, not in the tertiary care hospitals. It really has to be out in the front line, the primary ones, where the Maasai people come, and not where those that can afford it go to the better hospitals.
Thank you. Anders, I just want to make you a question that relates to what you have been answered, and knowing that you have sit in the board of the Global Fund, and so and you said take what it is there. I mean, Global Fund is the main provider of antimicrobials. And of course, being the main provider of antimicrobials is key to them to know that the antimicrobials that they are providing are affecting and working the people in which they are given. So do you think that in your opinion, should the Global Fund do more for the diagnostic of resistance? And in that way, how? I mean, how could we push for a little bit more of responsibility of the main provider of antimicrobials?
I think by not speaking about AMR, but speaking about what is needed, I think that's the way forward. Speaking about the lab system, the need for new diagnostics, for more rational use of drugs, for better primary health care, and seeing that AMR is a part of that, and those things that I was mentioning are part of the solution. I think that will help. Not making a silo, but rather, because what I've seen now during, we take the Global Fund for AIDS, TB, and malaria, and Gavi during the last 10 years, they have really joined hands when it comes to the surveillance, pooling resources, providing resources to countries to do an integrated support system when it comes to surveillance, not just for the 3 diseases or vaccines, but broadly. So they really made a big move there. The same thing on the lab. So instead of sort of pushing them to do more on AMR, see what is needed. Is it better lab? Are the labs able also to see whether those antibiotics are resistant or not? If not, push for that. Make sure that they have a comprehensive menu. But my advice would be to look at the different components that we need. This is just on the human side, and I know that the issues on the animal side it's more difficult because we have less resources there.
Frank, you wanted to say something shortly, and then I would like Sunita to say what you have been thinking about this discussion, since you are going tomorrow to be in the Stockholm Plus 50.
I'll try, and that was actually just a response here. I think that I do agree. It's just that sometimes the devil is in the details, and we very so often see the creation of these large laboratories, these white elephants that are only there as long as the money keeps pouring in. So if you should unlock it, yes, you should identify it, but you should integrate into the system that's there, and you should create some kind of selfishness, something of own interest there. And that could be, I really think, the front line, the clinical diagnostic, integrated with them, and not necessarily, the research laboratories. I think that we really need to integrate with something that's already pre-existing and not create these, typical white elephants that we do so often.
I mean, just one example from Rwanda. The Rwandan ambassador here to Stockholm, she's the former Minister of Health. She's looking for Swedish companies, lab companies, to establish themselves in Rwanda to be able to do exactly that. Yes.
Sunita, please. Shortly.
Yeah, I think just to say, I think what we have clearly, Stockholm Plus 50 really brings us to the point of saying we are living in an interconnected world. 50 years ago, We understood the environmental crisis, but in our own countries, I think 50 years later, when we meet, we understand the interconnection of the world. We understand it when it comes to COVID-19. We understand it when it comes to climate change. We understand it when it comes to AMR. But we also understand, and I think that's what we need to emphasize, and as a member of the Global Leaders Group, something that with FAO, with WHO, with UNEP, and OIE, we have been working on is also to understand the need, and I keep emphasizing this, for differentiated approaches, and approaches which respect where different countries are and find options, good ways in which we can all move forward together. And there are many such options available. We need to use them, just as you said, Anders. There are many options available. We need to use them. We need to use them with courage and with conviction. And I think that's really what Stockholm Plus 50 is all about.
Thank you so much for this rich panel answers. And thank you for the participants, both present and online, for being very engaged. I think this event has contributed to joint action and dialogue from a variety of perspectives, usually not present in the same fora. And the speakers in the event represented 6 countries and 3 continents, top-down and bottom-up approaches, global health, animal and environmental perspectives, advocacy and official views, all of them necessary and complementary. We have heard that there is a need for increased coherence, urgency, and focus. The AMR response requires that proposals are being deliberated in a unified fora, sufficiently connected, and for which there are expedite processes. COVID-19 has been a divisive pandemic of inequity and inequality, for which weak health systems and market drivers limited access to vaccines, tests, and medicines. We have now this example and these lessons learned that has to be applied in the response to AMR pandemic. All participants have highlighted the need for a multisectoral, whole government, whole of society approaches at national and global level. We have heard about the importance of AMR-sensitive and AMR-specific interventions and policy imperatives. In terms of the health economic case for AMR that has to be done, we have really learned the unfathomable cost of this COVID pandemic, and we need to be aware of the cost of inaction addressing AMR and the devastating consequences. We have also learned that decreasing AMR consumption is not enough. The importance of accountability, there has been a lack of accountability. We have also heard about the importance of WASH, that has been put, as a preventive measure that was evident during the COVID. And we have also learned about the co-benefits. I like very much the issue of the 4 Ps that you talk, Anders, that come from a country, from a person in an African country that talks about peer pressure, people, partners, and personal experience. Because I think that is one of the issues when we talk about AMR. AMR doesn't have a face like HIV or diarrhea or something. It's many multiple diseases. And maybe one way of getting to the people and changing minds is that we know the personal experiences. And this is something that has to be taken into consideration for the advocacy efforts that we have. I think we have heard from the aquaculture and the issues, because aquaculture is usually not present in many fora, and the fact that we cannot do everything at the same time in all countries, and we need to contextualize. And I also think that one thing that came forward is the One Health diagnostic capacity that is required to address and engage. Thank you so much to all of you. It has been a pleasure in having this session, and there will be a gathering now after. Maybe you will have more opportunity, the public here, to talk to our panelists and conversatories. Do you say so? So thank you so much, and good afternoon. I want to